Press button. Gosh, tack in. Right, welcome everybody. For those that are watching on the web and all here, happy Diwali, of course. It's today. So welcome to today's meeting of the Health Overview and Scrutiny Committee here at Leicestershire County Council. I'd like to remind everybody that it's being broadcast live via the County Council's website, and that also means it's going to be available also for viewing after the meeting. So can I please ask everyone to switch their microphone on when speaking and off when finished speaking, please. Also remind people to turn their phones into silent mode, which mine doesn't seem to like doing, but I will do it now. I'd like to welcome Ted. You're here instead of Maggie Wright, and you've been on before, so hopefully it's not too strange for you. No. Yeah, so welcome back. Now the intention is, because we have various external people attending as well, that we're going to discuss agenda items 8 to 10 this morning, and that means we then have a break for lunch and reconvene at 2 when we'll consider agenda item 10, which is development of the unitary structure for local government in Leicestershire. And I've also been just nobbled in the corridor that we'll have the deputy leader here for that session as well. Byron Rhodes will come and talk. It will be here available for us. So, minutes of the meeting held on the 5th of September. It seems a long time ago, but I'm sure it wasn't. Is everyone okay with those? Taken as read. Thank you very much. No questions have been received under question time. Number 3, questions asked by members under Standing Order 7.3 and 7.5. I've not received any. Advise of any other items which Chairman decide to take as urgent. I've not been told of any urgent items. Declarations of interest in respect of items. As ever with these things, we're assuming that members who are district borough councillors who wish to declare a personal interest on item 10, development of unity structure. So anybody that's going to declare on the district matter? There's Sarah, Dan, Ted.
Yeah.
Okay.
Declaration, a member of North West Leicestershire District Council.
Yeah. I was saying actually at the chairman's briefing, I mean, in fact, I'm actually a chairman of a parish council who probably won't be interested in taking on more responsibility, but I mean, there may be others that are. So we are probably now into the situation of looking at also people on parishes as well. Okay, that's noted. Member of Borough Council, indeed.
And I'm a member of
many
Charnwood.
of us that aren't. It's just a few of us. There's me and Amanda, I think, in this room who aren't. Declaration of party whips. Anyone declaring whips? Thank you very much. Presentation of petitions, understanding order 36. I've not received any petitions. So finally, we're on to agenda item 8, our first substantive item on Hinckley and Bosworth Community Health Services on pages 13 to 16 in the pack. The report's going to be presented by the interim accountable officer for West Leicestershire CCG, who is Caroline Trevick. Presumably you're still there for chief nurse, and you've got an awful lot of things on your hand, haven't you? And quality lead of the governing body. So anyway, over to you, Caroline.
Thank you very much, Chair. So thank you for inviting me today to bring an update regarding Hinckley Community Health Services. I think, first of all, I need to apologise for the brevity of the report. I know that I was pushed to try and give more information. There is a reason for this, and that I tried to cover in the paper, but I will explain up front. We did have a discussion of the business case in the governing body meeting in July this year, but when we went through that with NHS England, they felt that it needed substantial changing to be able to get through to their assurance process. So we are in the process of changing it. So if I was to bring what came in July, it would not be up to date. So what I wanted to do today was to bring you up to date with where we are with the intention of the CCG, and that's something that we've been working on since 2014 with the local population, local stakeholders, in Hinckley and Bosworth, but to kind of bring you up to speed with where we are in terms of the NHS England processes around this. So in summary, as I say, the process started back in 2014 when we met with key stakeholders, patient groups, counsellors, doctors, all sorts of people in Hinckley to talk about what needed to be done. We've got a bit of a burning platform in Hinckley with one of the community hospitals, and that's the Mount Road site, Hinckley and District Hospital. That has almost come to the end of its life and is still providing a small amount of clinical services there. So those services are day case procedures, which is operations and endoscopy procedures, but also a little bit of X-ray and some ultrasound. The intention of the CCG has always been to invest in services locally in Hinckley, and to do that we need to invest in buildings. The CCG does not hold capital monies and has to apply to NHS England for that capital investment. And so we are on round 4 of those capital bid investments, and that 4th bid is still in with NHS England, but the outcome of that is not known. And we were expecting that with the autumn budget that there may well be some kind of statement coming forward in the next few months. So, as I say, it is our intention to invest in Hinckley, in services in Hinckley, but to move some of the services, so the day case services, from the town centre site to the old Sunnyside site, Hinckley and Bosworth Community Hospital, so that we've got a proper 21st century day case unit for patients, and then keep the X-ray and ultrasound facilities in the health centre, which is next door to Mount Road Hospital, and then move in there the urgent care hub, which is the out of hours service, and the acute visiting service, to enable that to be more of a hot unit than a day case unit that the Sunnyside would become. So that's our intention. All of that is wrapped up in the circa £7 million bid with NHS England, and we have to go through the assurance processes for NHS England. And I said at the beginning, we're just in the process of getting that business case finalised with all the I's dotted and the T's crossed. And I think it's probably fair to say that their concerns with that was the fact that this is a journey that we've been over 4 years, and they wanted us to bring it bang up to date. And I think that's a fair assessment of it. So I think the key thing that we've been saying to the public is that without that capital investment, we would at some point no longer be able to manage the clinical risk that we are managing in the Mount Road site at the moment. And so at any point that we are turned down for capital investment, we may have to make the decision to disperse services elsewhere, which is of course not in line with the CCG requirements, but we may have to do that on grounds of clinical safety. So I shall pause there for questions and comments.
Right, thanks very much. Trevor.
Thank you, John. Succinct and to the point, and I appreciate the brevity. Can I ask, you got to round 4. Does that mean you passed 3 others, or is this the 4th chance at the bite of the cherry? And if that's the case, after that, could I ask how successful do you feel that you will be?
Okay, that's it. So the first question is easy to answer. It's the 4th round of the bite of the cherry. It's not 4 stages. It's really difficult to say how successful we might be, because across the country STPs are submitting capital bids for everything that they need to do. I suppose the thing that we can say is, as far as our STP is concerned, the Hinckley project has been graded as second most important across Leicester, Leicestershire and Rutland. The number 1 being the changes that are happening around Leicester hospitals, the £400 million bid. So I think having at the backing of the collective voice of the STP makes it something that NHS England could look favourably on. It isn't something that we're arguing amongst. Some people could say it's only a local hospital that doesn't actually have the importance across the system. But I think what we've been able to do is to demonstrate that the interconnectivity with what's happening around Leicester hospitals makes Hinckley quite important, because if we want to put more services out in the local area, we can only do that by investing in estate.
Yeah, I mean, I'll get David in a minute, but I mean, the point I was going to make is I live in East Leicestershire, South East Leicestershire, and I had occasion on Monday actually to go to Equivalent, which is St Luke's Hospital in Market Harbour, to have my ankle x-rayed. Now my appointment was 9:30. I got there at 9:15, being a good boy, getting there early. There's about 100 odd car parking spaces there. I had the last one. So are you going to be looking at adequate car parking? Because I mean, clearly if you're moving some of the services obviously now out of the centre, less people able to walk. There might be buses, but again, only if not very well, people don't go that. So just parking really.
Certainly, and that's a question that I've had many a time over the last 4 years. With the services that we're moving out to Sunnyside, there's good car parking at Sunnyside, but those services, patients don't tend to go on public transport because they are the procedures requiring some kind of sedation or something. So parking for people to drop off and pick up, yes, that's sufficient. What that actually does is releases a lot of space that is taken up by staff car parking in the town centre. And the conversations that we need to have is to make sure that the parking is appropriate. Currently, there is a car park around the health centre, which is overused, but it's also used for people parking going into town. So conversations with the Borough Council is really important about how we might do something to do that. But there is also a staff car park across the road on Mount Street that we've always said that if we give the hospital building up to NHS Property Services as we are required to, we would want to keep hold of the car park.
First of all, can I congratulate Caroline on promotion? I think that's well deserved, and I think everybody in Hinckley will be pleased that that's happened. I mean, I've been involved with this process since about 2005, when the original intention was to extend the community hospital and create a phase 2. Now that went by the board, and obviously clinical needs changed, and so we're now looking at for the last, whatever it was, 13 years, whatever it is, we've been looking at the alternative, starting in 2014 effectively, to move the endoscopy to the community hospital and the X-ray into the health centre. I think that the issues which this involves are well set out in this report, and it's bottom of page 13 and the top of page 14 makes it quite clear just how complex this is and how vital these services really are to look after the needs of the people of the southwest of the county. Caroline has actually spelt out this morning, once again, that unless this capital is forthcoming, then we're going to lose services. And I think this is really serious, because we've all assumed, of course, that things will improve and that we're going to get modern services, and that the process will take care of itself. But we're now up to the 4th bid, as Caroline has said, and the money is not yet forthcoming. The approval and the money is not yet forthcoming. Another issue which has hit us this week is the news that that the urgent day care centre. Well, the news came forward, didn't it? That the urgent centre in Blaby is now out for options, and it could either be at Enderby or Glenfield. And we can see in Hinckley that we're missing out yet again, because there's going to be this centre somewhere in Blaby, which is very welcome, and then there's a centre in Loughborough, and there's a centre in Nuneaton. And people say, well, Nuneaton's only a few miles away, but the traffic between Hinckley and Nuneaton gets worse by the day, and if it's urgent, then people are going to be in trouble if they're going to be caught up in traffic going down there. So we really do need the urgent centre as well, which is linked to this really. So I'm wondering, Chairman, whether you would accept a proposition that we recognise the seriousness of the situation and ask the County Council to lobby the Secretary of State on behalf of the people of the area and on behalf of the CCG to release the £7.7 million which is needed to get this process underway. I mean, I'm happy to put that as a proposition if you could accept that wording. Thank you, Chairman.
Everyone happy with that one? Yep. Clearly, you know, I mean, it's been waiting. I know you've gone through various iterations of the business case, but nevertheless, having had sort of a similar problem with delays in Lockwood Park, I'm aware of it, you know, it just needs sorting. And clearly, with the old centre, the old hospital sort of crumbling as it stands, it can't be done. And it doesn't sound an awful lot, does it? It's always easy to say that, but say it quickly. Okay, and so if we go for that, the people are happy to support that proposition, and that we'll ask the our executive basically to lobby on this behalf. I'm happy with that. Okay, thanks, Caroline.
Okay, thank you, Chairman. Yes, the report before you today presents the committee with an update on health performance in Leicester, Leicestershire and Rutland based on the available data at the end of October 2018. Some of the data in the report is older than that because it's the latest published data, but we will try and update you on one or 2 points with more recent data. So it does aim to provide you with an overview of performance issues on which the committee might wish to seek further reports and information, and to inform discussions and check against other reports as they come forward. If I could just introduce Pritesh Patel, particularly who's new to the committee today, who's seconded from UHL and deals with all of the Better Care Fund intelligence, including target setting, national reporting and supporting various projects. So if there's particular sort of questions around that area, Pritesh can endeavour to help you with the new targets. And you know Kate Allardyce, who leads on CCG performance, picking up some of the provider issues as well. So the report before you is similar to previous reports, does pick up the County Council's outcomes as well as some of the national reporting, particularly around the Public Health Outcomes Framework and the ASCOF Adult Social Care Outcomes Framework, focusing around 3 areas. If we could just talk through the Better Care Fund performance, and to start with, you'll be familiar with the guidance that came out in July 2017, which really focused BCF reporting onto 4 metrics, with a real focus on delayed transfers of care within those 4 and seeking improvement in that area. The BCF targets were refreshed in July based on revised guidance, so there are new targets that are included in the report this time round, with an expectation around delayed transfers of care that new targets are met by the end of September and maintained and exceeded thereafter. But also the other BCF metrics have been refreshed as well. The Care Quality Commission has been undertaking local system reviews of areas deemed to be sort of weaker on a number of the metrics, and a revised list was produced in December of areas to be reviewed, and Leicestershire has not been included in that process, which is, I think, a positive reflection of the good work that's gone on and good overall comparative performance at this point. In relation to the 4 metrics, permanent admissions of older people to residential and nursing care homes, and the full year forecast for this year is 921 admissions against a target of 890 admissions, and so it's been slightly over target for the first 5 months of the year, which we are looking to pull back later in the year. So it's reg rated as amber. It's generally an area that we've done well on, so there's a lot of preventative work that goes on, so we are doing comparatively well compared with other areas. But slightly at risk of meeting the target this year. And some further detail around that is set out on page 19. In relation to reablement and rehabilitation services metric 2, in the period April to June 18, there's been 91.9% of people discharged from hospital into reablement and rehabilitation that are still at home 91 days later, which is a key metric around the performance of those services. So ahead of the target of 87%. So sort of very positive picture around those services and what they're achieving. So that's reg rated as green. Delayed transfers of care. There's been a real focused system effort for 18 months or more on that area. And the latest figures are set out in page 11 onwards. The revised target for September 2018 is for Leicestershire to exceed 7.88 days in every 100,000 population in relation to delays. For the period April 18 to August 18, there's been a monthly average of 970 days, which equates to an average of 5.83 days delayed against a target of 7.88. So well under the target in overall performance, a real positive achievement and significant reduction through that focused effort right across the system. In relation to the breakdown of those delays, 88.3% attributable to the NHS, 7.36% to social care and 4.33% jointly attributable. Further details set out in paragraph 13. So overall, in summary, during the period April to August, there's been a 38% reduction against the same period last year. And in relation to adult social care delays, a 71% reduction. So again, a real sort of positive achievement from all in the system that have been focusing on that area. An application of resources through the Better Care Fund, improved Better Care Fund, and through the Adult Social Care Precept. And that does reflect work right across UHL, Leicestershire Partnership Trust, and out-of-county hospitals as well as social care staff. With Leicestershire, the recent performance is ranking as second out of 16 similar Shire authorities. So I won't go through all the details. There's some more information in the report about the work that's gone on to reduce delayed transfers of care. So yeah, a real sort of focused effort there. On metric 4, sort of a less positive comparative position related to non-elective admissions. This is an area which we've been rating as red for a number of months. Actually, this time round, we've seen some changes in the calculation of the targets because of some of the CCG profiling and some of the changed recording arrangements. So we are actually rating this indicator as green at this point, but that's more to do with changes to the targets than actual changes in improved performance. Last year was ranked 24th out of 32 counties in relation to emergency admissions, and it has seen sort of deteriorating performance overall over a number of years. So this is an area that still needs a sort of sustained focus, a whole system approach, and quite a complex set of issues that relate to that. So it continues to be a challenging area for LLR, but actually it is rated green this year, which means we will fall within our profiled position. It won't be worse than that based on current data. So there are some new approaches that are being progressed through the system, particularly a new approach around frailty. So I'm sure this is an area the committee will want to sort of maintain a focus on and potentially ask for further reports and information coming back on that. We have attached a new dashboard this time in terms of Appendix 3 with a slightly wider range of data in there with the metrics around length of stay and discharges at weekends, which does show that Leicestershire's ranked reasonably well. There's a slight error in the report. It should say 46th rather than at 41st and second in the nearest neighbour group. And I would envisage that we'll move into a better position as a result of the data this year. So that's available as context information. If you do want any further information around some of those metrics, we can certainly bring that back to you. So that's all I wanted to say on the BCF. Do you want me to hand over to Kate at this point?
Anybody got any questions on that particular, on the first section we've been talking about, the 4 metrics? Yeah, Dan. Yep.
Thank you, Chairman. If I could draw your attention to page 21 and paragraph 14. That's quite a startling figure when you look at 4,851 days lost to delay transfer of care. That's a phenomenal big figure. What's your thoughts and comments on that?
There has been a significant reduction over recent months, and that is a focus through.
Sorry, Mr. Chair. I understand that, the 38% reduction, but the figure is enormous still. So, you know, yes, that's great, but if it had been a 70 or 80 or 90% reduction, that is a huge figure. 4,851 days lost to delayed transfer of care for Leicestershire residents. A 38% reduction, but it's an enormous figure, isn't it? And it's not one that you can just say, well, okay, well, we're doing this, doing that. Something has to happen there, surely, to get that to a figure that is much more appropriate and tolerable.
Can I just add into that? I agree, it is a huge number of days that are delayed, but we're also caring for a huge number of people as well. Oh, sorry. So yeah, there's a huge number. So in terms of proportion, I think we're only looking at a very small percentage. So for UHL, it's around 3.5%. Sorry, the national target is that it should be 3.5%. At UHL, it's 0.7%. So I agree, it is a large number of days, but that's, as Andy says, a reduction, and compared to other people, that's actually a favourable position.
I quite understand that, and I know the statistics and percentages, I understand that, but it's alarming to see that number is very substantial. It's a real number, I accept that, and I admire your honesty and professionalism in bringing the report forward in the manner that you have. I'm just very taken back by that particular number, and the value to that number is very large. Thank you.
On that strand, then, as it is, as Dan's pointed out, still a good reduction, but a significant figure is still there. Can I ask how seriously that's taken, and what plans there are to bring that down even more, and whether you know and have analysed the hotspots that are causing that in particular? It is. I know it's a matter now of interpreting the figures, and I guess that's why you are a triumvirate here today, and we will go now probably to the figures to look at that. But it seems to me that is worthy of an action plan and a half, if I might be so bold.
So thank you for your comments. Just in regards to the numbers, it is across obviously the whole of Leicestershire and across the whole of the population of Leicestershire as well. There is an action plan, so we do have a plan in place to continue to reduce delays across the whole of the area and outside of the county as well. There are various schemes that we've got in place, working with all our partners within the area and also outside the county as well. A number of changes are staggered throughout the next couple of years. Some are in place at the moment, some are currently in progress. The impact of that as well will be measured. So there are a lot of schemes still currently in progress and are hopefully coming to fruition over the next months and years as well, to continue to reduce the delays that we've got across the area. And we're also working with partners outside of the county as well, to reduce the delays that are occurring outside of the area, which to some extent are outside of our control as well.
Chairman, thank you. I am more reassured now we've got into the figures as we needed to. I just hope that there are not recurring issues at the end of the day. I think that's something that we might want to watch. Thank you. Thank you.
Ted.
Thank you. On page 17, point 4, it says changes to performance reporting framework. And it starts, a number of changes have been made. So it says a number of changes have been made to the way performance is reported to the committee to reflect NHS constitution changes. The County Council has also developed a new outcomes framework, and the Health and Wellbeing Board has adopted some changes. Where are these changes explained briefly in point 5, or if not, could you explain what all these changes in reporting are, please?
Yes, it's not explicitly explained in the report, so I'm happy to take you through it. Prior to 18 months ago, when we had the county council election, we had a previous strategy for the council, as well as a strategy for the Health and Wellbeing Board, which links to the evaluation of the evidence, and that was refreshed with a new set of objectives, and that's fed into the reporting, particularly around public health priorities. So the dashboard that's attached is a kind of refreshed set of priorities with outcome measures linked to the county council strategy. So that looks a little bit different from the reporting you've had before. We've also, with the agreement of the Health and Wellbeing Board, not included mental health and one or two other areas in this particular report because of some of the challenges of getting accurate in-year data. So we felt that was better if there was proper evaluation of the provider agency's performance directly. So we are bringing forward reports specifically about issues around mental health and provider performance separately, both to the Health and Wellbeing Board and to this committee. So you can really have discussion with the lead officers from those agencies and get behind the data, the in-year data particularly, more readily. So we've moved the reporting more towards the CCG performance figures. So the information you have in this report today is the official CCG performance framework as it's reported to the CCG boards, which does pick up some of the provider issues as well. So it is broader than purely CCG delivery. So we did make those changes to the performance framework. So you had a real sharp focus on the CCGs, what their figures are saying, and their accountability system, as well as pulling in some of the provider issues. So it is a different style of report, which I think provides a real sharp focus and relates to national reporting as well. So the figures in here are what are reported and you'll see nationally in terms of the Public Health Outcomes Framework and the Adult Social Care Outcomes Framework, as well as the Better Care Fund metrics. So they were the revisions that were made and really to tighten up the process.
I don't know what the chair thinks, but in terms of receiving reports like this, my opinion, it would be helpful if a chart could be provided that explains what these changes are, so we're aware. So, for example, it would say the following information will not include this or will include this as compared to previous charts. That's the first thing. And in terms of some of the information provided, for example, on page 4, have I got page 14? Yeah. Sorry, it's point 14. Sorry, point 14. Yeah, so that's page 21. A lot of the tables, for example, on page 20 and page 21, don't compare to previous years, where, for example, some of the points actually explain that they do. So, for example, on point 14, that Mr. Harrison made a point about the 38% reduction. This is in bold. But then point 16 says, despite not meeting the national target. Now, I'm not criticising that per se. My point is that these tables don't show performance and figures versus last year, which would give the committee, in my opinion, a much better comparator as to how we are performing. It gives you a benchmark. And so the second question I'd like to put to the chair is whether going forward tables and statistics we receive will from now on compare versus last year, please.
I think that's going to be quite an ask, actually. I mean, the paper presumably developing all these changes were put to the Health and Wellbeing Board. So if we want to see that, we can get a copy of that. That will explain what the changes are. But to actually have to compare this year to last year and also all the other changes that have occurred, I mean, it'd be massive. I mean, you'd be looking at, huge thing. It'd be very complicated. I mean, the Health and Wellbeing Board have clearly moved on in terms of where the changes are. They've approved it. Basically, we have to take what they've done. But
okay, well, as a compromise then, certainly when it says a number of changes have been made, it would be helpful if the beginning of the report would list what we're not going to see or what we are going to see.
I think that's fair enough.
It's like when someone's selling a product, they will say, you know, this car now does this.
Yeah, what was it from?
And my final point is the gentleman, I do apologise, I forgot your name. Pritesh. I do apologise, Pritesh. You outlined that there were some schemes and plans in place. Would it be possible to for this to be outlined to the committee on paper, please, what these schemes and plans are?
Yeah, okay.
Yes, that can be made available. It's following with national guidelines as well, and everyone around the country is has been tasked to do similar things as well. So we can share that. That's fine. Just going back on your point about comparing previous figures, that data is all available. The targets that have been set this financial year reflect that performance as well. So the targets are in line with how we performed last year and how we want that improvement to go continue going forwards as well. But obviously, with the delayed transfers of care, it can be measured in such a variety of ways, and I think it was left out because we didn't want to obviously overcomplicate things as well.
Thank you, Chair. I just wanted to ask firstly, how did you decide on the period of time you're reporting on? I'm just curious because it kind of starts just as winter's finishing, and I was just wondering whether or not that was a deliberate decision or just following national guidelines.
So in terms of our performance and our metrics, we only have data up to a certain month that's completed and validated. So for example, we're in November now, but we won't get our delayed transfers of care data for September until tomorrow. So there is a substantial period of between 6 to 8 weeks where data needs to be validated.
It's more the fact it starts in April.
It's because we're starting from this financial year. We're measuring from this financial year.
Yeah, I just wanted to get that clarity.
Okay.
I just just wanted to mention I actually sit on the discharge working group that's kind of doing a lot of the work, and there's when it kind of talks about the extensive work that's happening around projects such as trusted assessors, I can absolutely testify to that. We do, as Healthwatch, still have some concerns around patient discharge, discharge transfers of care, and we are kind of looking into that. So it's certainly something that it's getting better, but it's got a lot of resources being thrown at it. But I'm not entirely sure that I think the picture that we see is the picture that this report is portraying.
Sorry, just to build on the points that others have made about the plan. Pritesh is quite right, there is a plan. I would agree with members, I think it's entirely appropriate if we circulate that after. I'm aware, I was just looking at the future unitary structure for Leicestershire item. And so on page 125 of the meeting pack, there is the appendix that relates to health and care integration. Now, again, if it's helpful at this stage, I suppose paragraphs 3 and 4 in that paper at least outline the bullet points of what the broad thrust of a plan looks like. So this is the Better Care Fund plan. There is other stuff working on as well. There is a budget there between health and social care partners of £56 million, which is around initiatives which are designed to reduce the number of delayed transfers of care, albeit the number remains as a big number. It's a good point, well made. So a number of issues there, which again, as Michael's involved in, around getting home first. How do we get people home as opposed to into a community hospital or other venue? What can we do around increased housing support to make certain that once they're discharged, they stay independent within their own home? What can we do to keep them safe within their own home? The use of assistive technology, etc., etc. So it's only a partial bit, but I wouldn't just want to say at this stage there's a plan. If that gives an indication of the kind of the broad thrusts of what the work is, that's maybe something which we can then build with the plan that Pritesh has alluded to.
Thanks, Mike. Tom.
Thank you, Chair. Very, very simple point. I think actually Mike has already covered it. To be able to discharge these people from hospital on a very simplistic view, there's got to be somewhere for them to go. And that seems to be the area where you're working on to make sure, but it is moving the problem down the line and making sure those people who are discharged from hospital are properly looked after, rather than being left in hospital because there is nowhere for them to go. Is that correct?
That's right. Some of the interim resources that have been provided through the Improved Better Care Fund, and through the Adult Social Care Precept have been applied towards care packages, so that there is enhanced level of care provided, so that people have got the relevant place to go, and they can move through the system quicker than they have. Now, some of that funding is only interim funding. It isn't sustainable long-term funding. So the long-term plan for health, and hopefully a longer-term plan for adult social care, when we see the green paper, clearly it's really important that there is sustainable funding in the system for both health and care, so that there are ongoing packages of care and support available in the community, so that this can be sustained. So this performance is based on some enhanced resourcing going in. There will be a question about, is that resourcing sustained, and can we maintain that performance moving forwards? But I do also think the non-elective admissions issue does create pressure on the system. So as well as getting people out of hospitals quickly, we need to stop them coming in the first place, and all of that preventative work needs to be high profile, and that's really the area this report's pointing to moving forwards around enhanced prevention. Some of it through adult social care work, some of it potentially through Mike's team. So that's a key part of this paper.
So really what you're saying is that the funding for the transfer of care into the community or to the community hospitals is only interim, and therefore your ability to do what you want to do is actually gauged by the finance being available to do it.
In the medium term, yes, that funding through the Better Care Fund is interim at this point. So I think it runs to 2019-20. So there is a question about sustainability beyond that point around adult social care.
And again, Chair, if I may, I guess BCF to some extent is a dedicated pot for initiatives to get people out of hospital, hopefully into the home, or at least out of hospital. Adult social care colleagues would be far better placed than me to cover the detail, but clearly there'd be work that would be core adult social care work around the care home market, the sustainability of the care home market, the choice that patients quite rightly have on discharge about where they go, and the limitations that could be. So I wouldn't want to say it's just around the BCF, because at some stage I suppose BCF becomes core health and adult social care work.
Thanks, Mike. David.
Just an observation, bottom of page 19 and onwards, we're talking about older people being 65. Now, most of the people are, well, yes, I mean, I regard these as youngsters, but most of the people I know of that age and a bit older, they're running marathons, they're sailing across the Mediterranean in canoes, they're trekking in the Himalayas. They're running county councils, aren't they? Deputy Lord Lieutenants, and sitting here around this table. I do just question this arbitrary age, which is now treated as old, because I don't think too many of us around here regard ourselves as old. Do we? Anyway, just an observation.
Yeah.
Well, Chair, that's a good point. Who does actually set that figure?
It's 65 is 65 because it's pension age, essentially.
Was the pension age?
But still is for the moment. Ladies only became available yesterday to be 65. But I've asked that question several times, I assure you, because adult social care is divided into those up to 65 and those after 65, and it's purely to do with that. That's what the message I got given. And there are, as you get older, 65 onwards apparently, there are other issues that are more likely to occur. Diabetes, the whole range, hypertension, and things that we'll discuss later on when we're discussing the public health report. Amanda, I think it was, wasn't it? Yeah.
Hi, obviously there's been a lot of conversation about the delayed transfers of care. Having been on the committee a little while, the situation is massively improved from the position that we had presented to us last year. And you can see there's been a huge effort that's gone into to improve that situation. It's already been drawn out how sustainable is that going to be going forward, but also how are we going to stretch ourselves in terms of ensuring that performance continues on the right trajectory. I think what was also interesting looking at the data is, over 65s, the discharge into other services is ahead of curve. Is that been part of the reason why delayed transfers of care has been pretty good? And what impact will that have as we go into the winter?
It's a good point. We're actually looking at readmissions into hospital as well to see what the rate of readmissions is, because if that's having an impact as well, has a knock-on effect with the detox performance. In terms of how sustainable it is, like I said, a lot of the work is still going on. A lot of the schemes are still coming into fruition as well. So we are coming into winter now as well. There has been money available for adult social care that the government have recently announced, so that will help to alleviate some of those pressures as well, especially around care packages. Looking at our targets for September and October going forward, initial estimates are that we will actually hit those targets, so we will meet those targets, which is what NHS England have set us out to do from September onwards, so that's a good plus from our side. But like I said, a lot of these schemes have yet to come bear fruition, and even the schemes that are that are live now, the impact of those schemes won't be seen until later on.
Okay, thanks very much. Andy, do you want to sort of... Oh, you're going to carry on, Thanks, Kate.
Okay, thank you. So I'll take you through the CCG performance dashboards, which are in Appendix 1 and 2 of the paper. So if I take you back to 2016-17, NHS England introduced a CCG improvement and assessment framework. That was then refreshed in 2017-18, and as yet we've not received a new update for 2018-19. So the dashboards within the paper are based on that 17-18 framework, but obviously the data has been updated to more recent information. So the framework provides a focus on assisting improvement alongside some of the constitution metrics as well, and the full dashboards within the paper were published in July 2018 by NHS England. We were expecting to get a refresh, an up-to-date position at the end of October from NHS England, but that hasn't yet been made available to us. So some of the data is a few months out of date. However, within the paper I have updated that with local information that we receive. So the tables that are presented in paragraph 30 identify some of the national metrics that are classified as at risk for East Leicestershire and Rutland and West Leicestershire CCGs. So I will take you through those and provide you an update where available. So the first metric looks at antibiotic prescribing, and there are actually two metrics that NHS England have set. First one is to reduce all antibiotic prescribing, and both East and West Leicestershire have achieved the national standard on that. The second metric relates to a specific number of, and they're called broad spectrum antibiotics, and East Leicestershire, although, as I say, they've reduced the overall number of antibiotics, they haven't reduced these broad spectrum antibiotic prescribing as much as expected. Within the table there's a number of actions that are taking place across ELR practices. So there are audits that are performed, the mandatory audits by practices to look at their antibiotic prescribing. There's shared learning across practices. There's awareness of schemes about not treating colds with flu, not treating colds and flu with antibiotics. So there's a considerable amount of work happening within GP practices. We've seen a reduction in these particular antibiotics, but unfortunately not yet to the level that NHS England are expecting. The second metric, which those of you who've been sat around the table will know and love, relates to cancer weights, specifically around the 62-day, and this is from referral to treatment. So this is seen as kind of the key cancer indicator because it relates to referral to first treatment. So it moves from GP urgent appointment to first outpatient appointment, decision to treat, and then finally receiving a first treatment. And the national target is that over 85% of patients should cover that pathway within 62 days. UHL have said that they should achieve this metric from December this year onwards, so obviously we'll be keeping an eye on that. There have been some improvements this year, and actually the number of patients that are currently on the that were on the backlog at the end in early October are the lowest that it's been since April at UHL. As you'll probably appreciate, considerable number of actions taking place across providers relating to the cancer pathway. So additional capacity is being brought in from Derby and from the Alliance at LRI. Some work's being undertaken with Sheffield teaching hospitals, particularly looking at gynaecology services and the cancer services that are provided there. There are weekly calls between UHL and CCG colleagues, and quarterly there are thematic reviews that are undertaken to find any common issues that are occurring on these breach patients. So moving on to A&E. So this standard relates to patients being admitted, transferred, discharged within 4 hours of arrival at an A&E department or an urgent care centre. So the table at the top of page 25 outlines the position for UHL emergency department and the urgent care centres, and that's currently at 85%. National target is to achieve 95% by March. You will see there that the urgent care centres consistently achieve over the 95%, and certainly between April and October the performance was around 98% for the 5 LLR urgent care centres. We are expected to see some changes nationally on these metrics, just as they recognise that there are changes within the urgent care system itself. So obviously as those come through, we'll be presenting those to you. Main reasons are that there are a high number of patients waiting for medical beds, and there's variability in discharges, particularly for medicine at UHL. There are some changes that UHL are working with DHU on the front door, and we'll see hopefully some improvement in performance as that becomes embedded. Next metric is referral to treatment, and this relates to patients expected to start a consultant-led treatment within 18 weeks of a GP referral. The national target for this is that 92% of patients should be seen within the 18 weeks. There's also a new national target which relates to the number of patients on a waiting list, and by March 2019 that waiting list should be lower than it was in 2018. So again, that's another metric that we're reporting on. There has been some improvement from the last month's level of activity at UHL. There's actually a 3% decrease in the number of patients that were on the backlog. Reasons for the underperformance is really around competing demands with emergency and cancer performance, and reduction in number of patients that are being transferred out to the independent sector. So as you'll expect, plenty of actions happening here. At UHL, every specialty that is reaching the 92% target and has a waiting list of more than 50 each have an action plan in place. And also UHL have now agreed that when patients are being transferred into the independent sector, that will be done at point of referral, which should then speed up the process. Okay, so moving on to page 26, just really wanted to pick up and let you know about some areas of improvement as well, because it all feels a bit doom and gloom. Dementia diagnosis, both East and West Leicestershire CCG are meeting the national target on that, that over 67% of expected number of dementia patients are actually recorded as having a dementia diagnosis, and West Leicestershire are actually the highest performing in their peer group. good point on cancer. One of the 9 metrics relates to first definitive treatment within 1 month of cancer diagnosis, and that has achieved its target for most of the months in 2018. DTOC we've mentioned. IAPT recovery, again, this is being achieved by both East and West Leicestershire. And another one that's been talked about for several years around patients that are waiting longer than 52 weeks. And at UHL in July, August and September, there were actually no patients waiting longer than 52 weeks. So that's good news. Okay. Take a pause for a second. So just wanted to mention some concerns were raised by a committee member regarding ENT and ophthalmology wait times at UHL. So there's some information contained within the report. This has come directly from UHL themselves and also the CCG planned care team. So I can take you through some of the comments that they've made on that. So regarding the ENT service, UHL say that patients are seen on average within 11 weeks and for follow-ups within 20 weeks, and patients are seen in order of clinical urgency. There has been additional consultant capacity within the ENT service. However, there has also been a 9% increase in GP referrals. So actually the additional demand has outstripped the capacity. But UHL are working with commissioners and the planned care team to look at managing the demand going into the service. Regarding ophthalmology, UHL say that most patients are seen within 9 weeks and an average of 3 weeks later if follow-ups are required. CCG have got a particular project on called High Impact Interventions, which is looking at the management of glaucoma and other long-term eye conditions. And finally, the CCGs are working with providers to redesign elements of both of these services to help improve the patient journey and also should have an impact on waiting times over the next year. Okay.
Thank you, Joe. If we went to page 29, and for once I'm absolutely delighted with the depth of and complexity of figures here. It's quite useful. And I'm looking at I guess really something called the resistivity of bugs. So I'm looking, I think, at broad spectrum prescribing, which is 1, 2, 3, 4, 5, 6, 7th down on the list there. And I noticed, okay, we've a red there. It was interesting. In the States, where I recently was for a holiday, my wife had an ear infection, and we had to go and invoke the pay-as-you prescribe and consult system, which we're not used to here. We just present and we're treated. And the first thing that the GP asked at the health centre was, you've been on tablets already? Yes, we said. So what did the swab test show? Now, we don't swab test, said my wife, for this sort of thing. No, that would have given you an absolute accuracy with regards to prescribing. We beat up our GPs terribly, and it's not fair sometimes if we don't provide a backup in terms of giving them the ability to be even more accurate in their prescribing. Do we have that facility in Leicestershire, and is it widely used?
I can't comment at all. Sorry, I'm not a clinician. I might look at Mike. Sorry.
No, we don't. I suspect the answer is we probably could, but the capacity of general practice to... I mean, there's a number of issues in my mind about why we wouldn't do it. The length of time that GPs have got on for an appointment, so the capacity of labs to then go and process the swabs and get back to them. I guess we run on a kind of, to some extent, best described as a pile them high and sell them cheap model, and that you come in, you either get your antibiotics or you don't. America, I suppose, has got a differently funded system. You know, I don't want to say you pay your money, it takes your choice, but that's what we get. We run, a large number of appointments at relatively short amounts of time. You get a reasonable diagnosis from a GP based on best knowledge in front of you, signs and symptoms. We probably could do something targeted if we wish to nationally around targeting, but I think that would take an awful lot of resource.
Thank you, Chairman. It just sits with me as that question mark, and Mike's more than adequately answered why we don't. But I'm just thinking that, you know, throughout the whole, therefore, of the NHS, is this a philosophy that we do a broad spectrum approach rather than a targeted approach? And I can't believe that we do that everywhere, but okay, I'll let it rest. It just sat with me as a little odd in view of the fact that you know, patients are paying for that consultation in America, really, by and large, and you need to get it right on the one shot. But okay.
I can give a bit more background because I'm a microbiologist by profession. I work in hospitals on this very thing, and have done at UHL many years ago. Yeah, I mean, certain tests, blood tests in particular, which are easy to get, you send them off to the thing, you get a result back within 2 hours. GP might not know that, but actually that's about right, electronically. Microbiology is a little bit different because normally you have to wait for the bugs to grow, and they don't do it in 2 hours. Although actually new procedures that are now doing, genetic procedures, actually you can get results back incredibly quickly, certainly within 4 hours. But nevertheless, what you're looking at is, first of all, you've got to identify the nasty little creature that's causing the problem. And having identified it, and there is something causing it, for example, you then have to go away and do some antibiotics on it. And that takes another length of time. And I think it's this time delay. And as Mike says, you know, you get 10 minutes there in front of the GP. They're expecting results back within a reasonable amount. To be fair, most people, if it's a simple illness, or a simple type of bug, actually get over it probably in a couple of days. So in fact, you're over it, and 2 days later, by the time the results are actually back from the lab. But it is an issue, and for certain, particularly these days, bugs that are, like we're saying here, these particularly resistant bugs, it is important, and we need to actually get it on top of it. I mean, I know of somebody, for example, that for years was treated with ampicillin because she kept getting sore throats. And when they actually realised, I said, hang on, have you had a throat swab? No. When they had, it was actually a bug that was highly resistant to the antibiotics she'd been on for years. And they changed the antibiotics, she was cured within 2 weeks. So it just shows you, you know. But again, it's down, I think, right, perhaps we are down to primary care, perhaps not having enough time to be able to do some of that these days. And that is a sad state of affairs. And maybe some of the nurse practitioners, you know, should be taking on a bit more of it.
Thanks, Chairman. Only a thought. Is there any learning? And I have an answer. Thank you.
Thank you, Chairman. Looking at page 26, cancer percentage patients receive treatment within 1 month of diagnosis. Yeah, when I go to 24 and I look down on your chart there, it's got cancer, which I thought I'd read or heard that it was within a month you can see your doctor and you can be on your way, because obviously with that sort of illness, time is of the essence. You've got 62 days here over 2 months, and yet here we're talking of within a month, which when I read that, I thought, oh, that's probably similar to what I've heard or assumed was the sort of the target within the first 4 weeks. You would have met the doctor, gone to see the clinician, and whatever happens then after that. But that's 62 days. That's a bit of an anomaly, isn't it, on these, the way it's laid out, unless I'm misunderstanding it. I am. Okay.
Oh, is that okay? Yeah. So there are actually 9 national cancer metrics. So 2 of them relate to 2-week cancer weights. So that's for an urgent first appointment. And then the other 2-week cancer weight relates to if there's breast symptoms. There are then 4 31 days, and that's dependent on first appointment, first element of treatment, surgery, radiotherapy, and then referral from a screening service as well. I think it's screening. They're not all in the paper. And then there are also 3 62-day cancer weights as well. And that relates to where you've got a consultant-to-consultant appointment. So there's a whole complexity behind all of this. So the 62-day one is almost the key one, and that's probably the one that you'll hear more in the press. But I wanted to flag up one of the 31 days because that is actually one that's being achieved locally.
So
I can send you...
achieving all of the other...
No, we're not. No. So we're achieving, this is just off the top of my head now because it's not within the assessment framework. So we're achieving the 2-week cancer wait, which for years we didn't. I don't believe we're achieving the 2-week breast cancer wait, and I can't remember the others now, but we're not. I think West achieving 4 out of the 5. 4 out of the 9.
Thank you, Chairman. I have concerns about that because that is an important issue. Cancer affects so many people, unfortunately. And if there are key targets and we're not hitting them, surely that should be part of our report so we can understand and we can see the evolution of how you've improved, and you knock down that one. You're not going to win the race every time, but you're going to start to see, because my colleague mentioned something about comparables, and this is what, to be able to see how long is those figures in the darkness and we don't know, whereas if they're demonstrated, we can see and we can look at that from time to time and think, oh, well done, there's an improvement there, but we don't know. All I've got is a 62-day and then a month, and I thought, well, hang on, now you've explained it, I appreciate it, I understand it. But I would share, if possible, on key elements like that I think most people would like to know. I think it'd be important. Thank you.
So the outcomes framework only reports on that 62-day cancer wait. As I say, there are 9 national metrics, and as a performance support to CCGs, we present on a monthly basis, all 9 obviously. Nationally, there are over 100 performance metrics, whereas only half of them are picked up within the assessment framework. So you're only getting half of the whole picture, I suppose. In previous years, we have presented, haven't we, a lot more metrics, but certainly over the last year or so, we decided to try and narrow it down so that it's looking at the assessment framework rather than bombarding you with lots and lots of data. But we can look at a happy medium if you think that's more sensible. Yeah.
Janice.
Yes, I raised concerns about the waiting times for appointments at the ENT, which can be up to 6 months. And this has obviously a detrimental effect on patients, and I understand the eye clinic is in a similar situation. And I'd like an explanation as to why this prolonged waiting time is so long for some people. I ask about the government guidelines for patients' waiting time, which is in the report as 18 weeks. And in the report it said a waiting time of 6 months is not typical of the service, but it is happening, which is an awful long time to have to wait for an appointment. Hinckley Eye Clinic is having problems because I've actually had to ring up regarding not hearing from them, and they're about 4 months behind to get an appointment. So there are problems, and I think this is the kind of committee that we have to bring these kind of concerns up, and we do need answers. Because how long have we got to wait for appointments if they're running so behind? What is the actual problem? Thank you.
Okay, so I would suggest you probably take that up with UHL directly themselves. I mean, obviously, I'd suggest you take that up with UHL directly. So we're not providers of healthcare services. We're here to report performance for CCGs, and some of that obviously crosses across providers as well. I mean, as I said in the presentation, then I did get quite a bit of information, and this is the information that I got from UHL specifically relating to that. So I cannot comment on particular concerns or issues within UHL themselves.
Yeah, thanks, Kate. I appreciate that. I mean, I was talking to Michael Smith here from Health Watch before the meeting started, knowing that this might well come up as an issue. And I've a little bit of experience myself of having to wait in outpatients there and never actually ever getting a reappointment, even though that's what I was promised. I think this needs more patient-focused analysis. So I was wondering whether maybe it might be something Health Watch could put on their list of many things they've got to do, is to have a look at perhaps ENT and ophthalmology, because it's clearly got a big issue. They've got a new consultant, but then on the other hand, we've now got 9% more referrals coming in. So there's clearly, a lot of in and out and so on. And it may well be that patients sitting there actually in outpatients, it may well be worth having a go at them. But anyway.
Thank you. Without kind of wanting to divert too far from the topic of conversation, there's been a lot of work over the years from the local involvement networks to Health Watch around ophthalmology, the patient experience, the delays within the clinics themselves, which I'm more than happy to share, and we've always taken up directly with UHL, so I get that. We're also going to be doing some work around cancellations and how that is impacting on members of the public and the patient lives, so we'll be doing some work around that too. I just really wanted to ask a question, and maybe you kind of have already answered this in something you just said. I'm surprised there's nothing around never events within the report, and given how many there's been at UHL recently, is there any consideration or conversation around whether that's maybe something you might report on?
So similar to the cancer weights metrics, we present those to our CCG boards. It's not never events are not part of the assessment framework, so that's why they're not included within here. But they are certainly through the assurance process that we have with CCGs, and generally we'll provide just an update. They're also included in the UHL board reports as well. But yeah, they're not. NHS England haven't recognised them as being part of the CCG assessment framework.
And maybe, Chair, just a consideration for the board. I don't know if everyone's aware about never events and the clinical issues that should never occur. And there's been an alarming number of them at UHL over the last year.
Yeah, quite. So we'll discuss. Yeah, Sarah, you're next.
Thank you, Chair. I mean, never events used to be reported here. And near misses, I think, as I recall. And I think this has become so focused. I mean, this is just a criticism of Jem. This is the way the process has ended up. This has become so focused on what the CCGs want. It's slightly different from what our remit is. So maybe we have to think about that separately, about what we want, what we ask for. I'm going back to the point making about earlier on, people making about cancer weights and the complexities of the measures. Maybe we could have a separate paper about what all the measures are, how we're performing over time, and so we get a proper understanding of what the situation is and has been. We could even just be for information, so we're fully clued up. That would be a suggestion, Chair.
What isn't clear to me from this report, looking through it, is it any cognizance being taken of the fact that those of us in southwest Leicestershire quite often don't come into Glenfield or the General or the Royal. We go to the George Eliot in Nuneaton, and I'm looking through all the, for example, the better care, the better care provision on page 30, and having been into the George Eliot quite a few times in the last few months, most of the headings here seem to apply to the George Eliot, with the more serious cases obviously being taken on to the Coventry Walsgrave, as we called it, or the UHL that it's called now. So when we assess the situation as we're doing this morning, are we also, is there a parallel report somewhere relating to what actually happens in the southwest of the county?
All the southeast to Kettering.
I mean, the same applies obviously to going down to Kettering, as you say.
Oh yeah, absolutely. Around the whole edge.
I never really, if an ambulance turns up, I'm never clear about whether we're going to end up in Leicester or in Coventry or Nuneaton. You know, you're usually out of it at the time, but I mean, you wake up and you find yourself across the county border, and excellent service, incidentally. But how are we assessing performance, or does the performance of the Warwickshire units come to this committee at all?
Okay.
I'm guessing here, but I presume this is related to the CCG.
It is. So it's a CCG population. So, for example, the referral to treatment and the cancer metrics would include patients that are going to George Eliot or to Kettering as well, or Coventry. So it will be included because they're the CCG population, I suppose. Also, we present to CCG subcommittees an out-of-county position. So last month I presented at West Leicestershire Quality Performance Subgroup a dashboard which looked at all of the metrics but only related to West Leicestershire patients going to George Eliot or going to Coventry. So there's a lot of detail behind. Also within the Leicester City contracting team we have an out-of-county contracting department who are specifically there to look at the issues around those out-of-county providers. Okay.
Looking at the detail of these pages, obviously there's a few significant differences between East and West. I wondered if you could sort of delve into a couple of those. So I know we've talked about the 62 days of cancer referral in detail, but actually the East performance is 73% and the West performance is 81.5%. That's quite a significant difference. But then when you look at the 1 year survival, East is performing better than West in terms of the percentage marginally, but there is a difference. The other is the 4 hour wait. When you look at the performance from East, that's at 70%, and when you look at the performance of West, that's at 74%. Is there any significant stats that sit behind those bits and pieces? And is it GP performance, or what is it in particular that's creating those differences?
Okay, so I need you to turn your thing on. It relates back to the previous question, so it's about the out-of-county performances as well. So it will. That's basically the reasoning behind the 4 hour waits, because obviously you'll have patients at East that are going to Kettering, you'll have patients at West that are going perhaps to Nottingham. So their performance or how long they've waited will impact on that overall performance. And then the 1 year survival for cancer, that's really dependent, and Mike might have a comment about this as well, about the types of population that you've got within those areas. So that's where there'll be some perhaps significant differences. It's either the providers that your patients are going to or the demographics of the population.
Sorry, what was more significant was the 62. It was a 10% difference between East and West.
Yeah, and again, that will be because performance perhaps in Nottingham is better than it would be in Kettering or Peterborough. So that will be where the difference is. I think we've got about 25% of patients go out of Leicestershire for their treatments. So, so it's quite a significant amount. Okay, but they are all monitored on a regular basis. Okay.
That's a big number. Quite surprised by that. Okay, the final section then in this part, I presume, are you going to talk about this, Mike? Or are you going to do it as well? Yeah, this is the public health outcomes performance, Andy.
Yes, just to pick up Appendix 4, I'm conscious you've got a full report from Mr Sands next on the agenda around public health performance, so I'll just sort of pull out a couple of points. The Appendix 4 contains 39 indicators taken from the Public Health Outcomes Framework and tied very closely to the outcomes in the County Council strategy and key areas of public health service delivery. It's constructed on the basis of statistical significance from the England average or relevant service benchmark, done on a sort of simple green for better than the benchmark, red for worse, and amber for similar to. Out of the indicators, 18 are green, 12 amber and 2 red areas. Of the 18 green indicators, there's been significant improvement over the years in relation to under 18 conceptions, new sexually transmitted infections and smoking status at the time of delivery. But no significant changes in relation to excess weight for 4 and 5 year olds and 10 and 11 year olds. Leicester is better than the national average for those weight figures, but also those figures are higher than we want them to be, so that continues to be a priority. There has been some data out recently that suggested there'd been a worsening of the figures that's being looked at by the analysts. We think that's a sort of recording issue in terms of interpreting the guidance rather than an actual issue, but we will sort of come back to you on that once that's sort of clarified.
So I'm aware that unlike some of the other providers, I'm in a position to sort of answer for my sins. I think I'm loath to say too much in a public meeting, but yeah, when these figures were published this year, we've had some years where childhood obesity in Leicestershire has been less than the national average, and we've made some progress in reducing it. This year's figures for Leicestershire went the other way. They were all of a sudden above the national average, almost totally driven by Hinckley and Bosworth, which, if you believe the figures, would suggest it, you know, to be blunt, the fastest place in the country. We looked at those figures. Frankly, I didn't believe them. Colleagues have done a bit of a dive, and again, we suspect that there is an issue with the measurement at source, which has then gone and mucked up all the BMI figures and the rest of it. As the police would say, it's a fast-moving investigation, so I can't necessarily say too much about what the issues are. Suffice to say, A, we're dealing with it, and B, I would put a big caveat around paragraph 38. I don't want to say don't believe the data, but actually we do believe there's a systematic problem with the data this year.
We talked about cancer figures. Paragraph 39, breast cancer screening coverage and cervical cancer screening coverage has been areas that's seen some decline, worsening performance over the last 5 years, also witnessed nationally. In relation to the amber areas, child dental decay, has been some improvement in the figures in 2016-17, latest figures that are available, so that's good. No significant change in relation to completion of drug treatment for non-opiate users. And in relation to drug treatment for opiate users, there's been a worsening trend of performance. So clearly areas of focus there moving forwards. And the two red indicators that haven't changed for a little while related to chlamydia detection rate and NHS health checks take-up. So further work is underway through Mike and the team in all of those priority areas. Certainly not helped by the low level of funding that comes into the public health grant and also reductions in recent years. So it is hoped that in the settlement for the NHS, the £20 billion, and also there's a lot more rhetoric around prevention, that that does translate through into resourcing, because there are some serious public health challenges in Leicestershire moving forward. Air quality has moved up the agenda recently as well. I think that comes up in Mike's report. So there is a real significant focus of work moving forwards, and the funding doesn't really match up to the challenges from what I can see moving forwards, but I'm sure Mike will pick up some of the themes in his report.
Thanks, Andy. Well, I see the Secretary of State seems to have got a bit of the message, because he's now talking much more about putting more money at the front end, the prevention, than he is at treating people at the back end. So, but then, you know, that's words. Let's see some action and some money. Yeah. Okay, everyone okay on that? Right, well, thank you very much. That's,
Chair?
Yeah, sorry, Ted.
Could I double check, please? Where are the figures where we can compare? How do we reach those? I know you said they were available. Could you explain how and where they are available again, please?
I will circulate after the meeting some further details with web links. I think if you are interested in delving down into some of the national data and comparators, there are some good websites and web sources available with comparative data on them. So we've got a colleague, a public health intelligence specialist, who sends her apologies today, but I'll liaise with her and make sure you're circulating some really good sources so you can get behind some of this in further detail.
Thank you.
Amanda, I think you...
Hi, thank you. I noted on the report that we don't have any data for breastfeeding, and I understand there's a statistical reason, but could we start providing information where we've got something, or provide something valuable, that even in the narrative of where we think the position is? That would be helpful.
I did look into this after you raised it earlier on at the briefing. So, yeah, it's another one where there's fairly strict conditions around the percentage of women who have their breastfeeding initiation kind of asked for and then recorded on the system. We didn't quite make the threshold to make it valid. I did check with Natalie, the colleague who works with Andy, to which the answer was, yes, the coverage rate has now been achieved for 17-18, so the data is now above that threshold. So updated data was only published in the Public Health Outcomes Framework 2 days ago, which is not why it's not made it into the Scrutiny report. Latest prevalence is 45% breastfeeding rate, significantly better than the national average of 42.7. So again, the figures have always been there, it's just getting it above the data quality threshold. It's not in the email. We always know that there's a difference between breastfeeding rates in the east of the county, which tend to be higher than breastfeeding rates in the west, so we tend to do a bit more targeted work in the west around peer support for breastfeeding, you know, on the grounds that actually people, women who've been breastfeeding themselves are best placed to support and educate other women to breastfeed. So the answer is 45% higher than the national average.
That's good. Thank you. Good question. Thanks, Amanda. Thank you, Michael. Right. So thank you very much for the performance report. A lot of good questions there. Bit of action for the future. And let's see, hopefully the next time we get a report, things are improving more. I suppose is the obvious one, isn't it? So agenda item 10, this is the report by the Director of Public Health on challenge of frailty and multimorbidity. So we've fortunately got Mike Sands here, so he's going to take us through this. Thanks, Mike. Let you settle in.
Right, yes, thank you, Chair. So the purpose of this report, as the covering paper says, is to present my annual report for this year. I know most members would know this, but for the benefit of those members who are new to Health Scrutiny, the covering paper just takes you through a bit of a background to this. So one of my statutory duties is to produce an annual report that's the independent report of the Director of Public Health. As paragraph 4 says, it's done by, I need to produce a report on the health and wellbeing of the people of Leicestershire. I do that by reporting publicly and independently on trends and gaps in the health and wellbeing of the population and by making recommendations for improvement. For this year's report, I chose to look, originally I was going to look at frailty, based around the feeling that as people get older, they get more frail, and that's the driver for demand on health and social care services. When I dug into it a bit more, I actually thought the issue was as much about what's called multimorbidity. So the growing number of people in the population who have 2, 3, 4, 5 different health conditions, not just one individual health condition, and the feeling that that, more than the growing number of older people, is the key driver for demand in health and social care and the attendant cost that goes with it. So hence, Leicestershire's Health, the challenge of frailty and multimorbidity. I know on an earlier report we talked about the brevity, but I'm sorry, I can't help diving into the detail, so do bear with me. I'm pretty certain, well, I know some of this stuff around the growth and number of older people we've covered in previous reports. So either one of my previous ones or one that Peter Marks, my predecessor, did, we looked at the growth in the number of older people, the kind of stuff that then goes in the Joint Strategic Needs Assessment. And we've got familiar with talking about the increase in the number of older people, a number of much older people, 85 plus in the population, and the demand that puts particularly on social care colleagues. So that was one we did, and then last year I did that kind of broad infographic spectrum looking at a whole load of things in the population, and there I remember one of the slides was around the difference between life expectancy, so the number of years on average you can expect to live, and healthy life expectancy, the number of years that you can expect to live in good health. And the difference between those two almost being that kind of group of people which again are more dependent on health and social care services. So some of this I've covered before, but I make sort of make no excuses really for putting it back in this one, because I think some of that background data does help set the scene for some of the cost drivers. So to take you through it, I'm aware there's a lot in there, but just to highlight one or two individual pages. Page 54 of your of the meeting pack presents that sort of broad brush population projections for Leicestershire, both now, 2016 being the latest data, the top left-hand graph of the four, and what we'd expect the population to look like in 2041. So those bars, you've got males on the left, females on the right, different age bands. So these are the numbers and predicted numbers in 2016 and 41, aged 0 to 4, 5 to 9, 5-year age bands all the way up to 90 plus. I guess the key point for me is it's fairly stark. We always talk and still do talk about population pyramids, because traditionally you'd expect the population to have a lot of, kids get born, and then gradually as we get older, we expire, and you end up with a limited number of people of a certain age at the very top. But you can see from there that the population pyramid looks nothing like that nowadays. Even in terms of population in 2016, the best you'd call it is probably a population muffin, looking at that. No pun intended about obesity. But it does show, if you like, the growing number of what might be called late baby boomers, so people born in the 60s, late 50s, 60s, those kind of big bars in the middle there, actually single biggest part of the population in any one 5-year age band, much more so than other parts of the population. So I think I've said before, in terms of what that means, in terms of demand on health and social care, and from a tax point of view, you've got people nearing retirement with less people actually in work that are paying tax to care for them. So it's an interesting point in itself. If you look at 2041, you can see that becomes even starker. So a growing population, I don't know, that whatever you call it, that's not a pyramid. You've got the kind of squaring out of that pyramid at the top as more people live to a ripe old age. And that should be a good thing. I mean, Mr. Bill kind of rather beat me to the point earlier on by talking that actually ageing shouldn't be anything other than a wholly positive experience. And many older people contribute to civic society and the communities in life in many different ways, one of which may or may not be running the county council. So there is an element of, I didn't want this to be a report that just looks like the growing number of older people and go, woe is me, what we're going to do about people living longer, because really it should be a positive thing. We should celebrate that. But there is this issue about what do we do about the gap between healthy life expectancy and life expectancy. So I go on to give a number of graphs over the following pages about the number of people in the community that have certain diseases and conditions, such as diabetes. You can see on page 61, I think it is, around depression and anxiety. Although it's not a huge increase, there is, for instance, a kind of increase year on year in the number of people who are recorded on GP practice registers as being as having a diagnosis of depression. So again, there's some interesting stuff there in individual conditions, even if the whole point for me is to take you to page 67, I think it is, which is the key slide around, it's a key slide for me around prevalence estimates and multiple morbidity. So again, as I said, the number of people who aren't just living with a single condition, but with multiple conditions at the same time. So that bit on the right-hand side, well, as you would expect, there is a link with age and with the gap between healthy life expectancy and life expectancy. So as you get older, you are more likely to have multiple health conditions, and we'd always know that. But the paradox for me is the right-hand one, where if you look in terms of absolute numbers, and the column which says 2 or more chronic conditions, although there are predicted to be, or there is a prediction that 12,535 over 85-year-olds living with 2 or more chronic conditions, there's actually, in terms of absolute numbers, more people aged 25 to 44 that have got the chronic conditions. So multimorbidity shouldn't be about age. It should also recognise that if you think about diabetes, the press reports are around more younger people being diagnosed with type 2 diabetes much earlier. So the kind of stuff that years ago would never have happened in childhood, in the 20s and the 30s, type 2 diabetes was like, 50, 55 plus. You're beginning to see that not just be a kind of interesting example of people going down with diabetes, but they're then getting other conditions, and that's then beginning to drive the real demand for health and social care services, particularly health services, I guess, in that instance in the population. So there is something about the older population, but if we just say it's about that, it's the wrong thing. So the key cost drivers really are how do we reduce the number of people living with multiple morbidity. And then go on to provide a number of graphs around admissions from certain conditions. Going back to frailty, so switching back to it, there's obviously a link between multiple morbidity and frailty, because you're living with these conditions, you probably could end up in a frail condition and be more likely to be admitted. But the kind of age deprivation balance, I suppose, is interesting. So that shaded map, you can see there that, I guess in public health terms, we normally talk about admission rates being higher in the more deprived areas. But if you look at the map of Leicestershire, that kind of combination of age and deprivation means that's really quite an interesting picture, which to my mind goes a little bit down the southeast of the county, then along the west of the county, but then a band around the centre. So it's actually quite a challenge, I think, to existing health services and where they think about demand would be coming from in terms of admissions from frailty. So again, I thought that was an interesting one for me. Lastly, to end on, there's an element of, well, what do we do about it? I could have spoken at length about the sort of things we spoke about earlier on around the Better Care Fund and all the work that I'd recognise health and social care colleagues are doing to redesign the system. Certainly, it's a shame Cheryl's not here, the work that she's been doing, Cheryl Davenport as Director of Health and Care Integration around the integrated locality teams would be a good example of trying to move to what I've called for, which is not treating a health service that doesn't treat individual conditions, but treats the person. Because if you just go along and get your diabetes sorted, and you get your, this, that and the other sorted, a number of issues can arise. We talked around polypharmacy later, so if you get one medicine for one condition, one for the other, the way they interact can throw you well out of sync and to some extent makes things worse than where you were in the first place. So there is something about moving the health service in particular to treating people holistically, to use a well-worn buzzword. But then for me, it's also then pulling back to some of the traditional messaging about how do we encourage healthy ageing. Some of that is life course stuff, so the usual public health messages about healthy eating, healthy drinking, giving up smoking, doing physical activity. That is absolutely valid if we're going to get people to live into a healthy ageing. I've put some recommendations there around targeting some preventative stuff for older people, multi-morbid people, so frailty, falls prevention programs would be a good example of the additional stuff I think we need to develop in addition to the kind of universal messaging around public health. And then there's also something, I suppose, recognising broader links around loneliness and social isolation, connectedness with families and individuals and their communities, which is why I put a piece in there, a recommendation around extending and continue to develop our social prescribing model. So recognising that GPs, when they do have an interaction with the multi-morbid, are best placed to direct people towards stuff in their community that can help keep them independent and help foster that sense of healthy ageing. So there's an awful lot in there, but I almost kind of wish I got to the stage where I now want to start from here to start thinking about where we go with it, because I thought the data, it's limited. There's not as much there as there are other in areas because this is an emerging kind of pattern, but it certainly lends itself to a big debate, I think, with health colleagues in particular about the way services are developed and about the way we go about supporting people in our communities. So the recommendations really from that point of view I think I'll cover in paragraph 9 of the covering report. As always, I'd like to thank in particular Natalie Davison in Andy Brown's team, the data and business analyst, who really has probably done about 60-70% of the legwork around the infographics, which I think make sometimes dry stuff come alive, and also the narrative around the other bits. There are a number of typos in there, which I'm sure you've picked up. Which I'd always welcome you pointing them out to me. All I can really say is all the good stuff is Natalie, all the errors are mine. I'll pause there.
Thank you very much, Mike. Yeah, as ever, fantastic set of information here. For me, in my age group now, I think this is like a sort of a manual. Read this, you know what you've got. Sarah.
Thank you, Chair. I agree. This is another excellent report. Interesting, even it poses a lot of it gives you a lot of information and gives you a lot of questions and thoughts, and it's great. I mean, one thing that popped out from my mind was the life expectancy graphic on page 55, where since 2009-11, average life expectancy sort of gone up by, a few years, but I don't think healthy life expectancy is necessarily keeping pace quite as well. So that was one thing I thought that's interesting. And then you look at page 67, that thing about the younger, all ages and people who are younger having multiple chronic conditions, it kind of ties in. And of course in America, their life expectancy is starting to drop. So, it'll be interesting what happens next. And I agree completely about treating the whole person. My own sort of family and friends and stuff experiences of the NHS, there's wonderful specialists, but they don't always necessarily treat the whole person. And if you do one diagnostic thing, you can actually say, oh, it all stems from this, rather than 4 different things. So I think it's a very good point, and I think health do need to start thinking in that terms. I have a specific question about sight loss, because our rate of sight loss certification per 100,000 people on page 63 is slightly, well, it says significantly, but is higher than the national average. Yet the 3 main drivers, I guess, which are age-related macular degeneration, glaucoma and diabetic eye disease, are lower in the main than the national average. So I wondered what was driving what other factor have you not seen that's driving the higher rate of certification? Or have we just got an extremely enthusiastic consultant somewhere signing people off? I don't know. It just struck me as a bit odd that those two, the way those figures come out. I just wonder if there's any underlying thing I've missed on it, Chair.
It's a very good question. I must admit I'd have to go away and look at it. I'm assuming the difference is sight loss caused by things that aren't glaucoma and age-related macular degeneration and diabetic heart disease. Yeah, what they would be, I would have to look into it. It was an interesting one. I was thinking, is this to do with certification? But then that would also come through in the other 3 sub-bits, wouldn't they? So, yeah, it's other. But it depends what other is.
Michael.
Thank you, Chair. Having to read so many different reports, actually, this was quite enjoyable. So I'd kind of agree with the infographics. So, yeah, thank Natalie. I would absolutely agree as far as the multimorbidity, and it's certainly something that we hear a lot from members of the public, that, there's kind of assumptions that as you get older, you face certain issues and certain health problems, but it's more and more kind of the age differentiation is becoming less and less of an issue. So I think highlighting that is certainly something that I can only applaud. I did just want to kind of mention one thing around the social prescribing. On a personal level, I cannot tell you how delighted I am that you're highlighting social prescribing. I cannot commend it enough for being such an effective tool to help people that present to the GPs for things that aren't medical issues. There's social isolation and lots of other factors. But the model that you're suggesting is that there's a referral from the GP into the council services, and you're saying about First Contact Plus, and some of the models have had the kind of social prescribing actually happening within the GP services and within the practice themselves, and if that's something to maybe take away and consider.
It's a debate. It's a debate that we had for some years in Leicestershire. We did talk, and we should come back to the role of the patient participation groups in general practice, because for me there is a group of people there who would be linked into the practice who are probably best placed to know what was going out. We said we'd try and make that part of the model, and I must admit we probably need to revisit that. Philosophically, and again I think this is where maybe me personally is a little bit different. I mean, again, Matt Hancock in his speech on Monday around prevention mentioned the role of social prescribing. How shall I put it? There is a risk, and the model that you're talking about is almost a question of the NHS comes along and says, right, we need a social prescribing service, and we're going to put the social prescribing service into practice, and we're going to sort out everybody's problems in life there and then. And I kind of don't get the logic of that, because I thought the point about social prescribing to some extent was about trying to keep people away from the practice in the first place. So if you set up a service that's kind of based around the primary care, it's like, hold on, I thought we'd try not to do that. So that one, I guess, recognises that when people go into the surgery, there is that teachable moment, whatever you want to call it, where the GP will say to you, if you've got a problem, you know what, I think it'd be a good idea if you were part of a walking group, or why don't you take a prescription, social prescription for a knitting group, knitting that or whatever. But actually then want to hand them over, get them out of the surgery and get them linked into their community. So First Contact Plus isn't, wouldn't call it the council service, but it's supposed to act as the front door to the range of everything else that should be out there in the community, which people aren't aware of. Now, some of that will be my services, some of that will be district council services, some of it will be stuff that's being delivered, or quite a lot of it will be stuff that's being delivered by the voluntary and community sector. So the First Contact Plus bit is almost trying to take away too much dependence on the practice and the GP, and to say that what the NHS needs to do is the prescribing bit. What other bodies, particularly local government, do is the social bit, and that's where the social prescribing model is. I mean, so it's not about going, there's your social prescribing service, let's do the prescribing bit, and then we can take care with the preventative services we've got in our communities to do it that way around. And I do sometimes think, maybe it's just me, but I sometimes think the model that is being explored nationally is almost kind of like as if local, well, to be blunt, as if local government wasn't there doing this kind of stuff for years.
Ted.
The first point, I don't want to be seen as a criticism. It's a request I'd like to make to the chair in terms of the the report that's given to members of this committee, could I request that in future we could receive it in colour? Because, for example, you see, the thing is, by asking this question, it would seem as if I'm being critical, but the following questions I've got aren't. But, for example, on page 65, your 19, where we've got heart attack, stroke, obesity, diabetes, depression, without sounding flippant, this is almost like an eye test, because you're having to think which is which. And it was such a mental and physical challenge that actually it took away from actually working out which was which. So that's a small look. On the grand scheme of things, I appreciate that to run off a lot of copies, especially when we're practicing prudency because of our overarching budget. But I think for member people that are on this committee, I don't think it's a big ask. So that would be my first request. But if I can go on to the actual questions. So understanding this report, then it does focus more on the multi-morbidity in the older section of society. So would this be why the reason that there aren't figures in this for the amount of people that came through the smoking cessation service, or the addressing? I mean, you see, for example, I'm sure all councillors get the LJ magazine, and there was reports probably beginning of this year that there was an interview with Simon Stevens, and his quote was that sugar is the new smoking. But of course, I appreciate there's not, because of the direction you've taken this report, there's no action on that. But in terms of your work, how much will you be doing towards things like that? And obesity, I know you've used the words, I will renew my call on page 86. Would that suggest, this is my final question, that your previous calls... exactly. Because really, and the final point is, surely one of the biggest drivers of some of the health conditions is the public's over-reliance with the car. We're just not walking as much as we used to. I mean, we really aren't. I mean, children being dropped off right outside school, being picked up right outside school, and it just extends right across the piece.
Yeah, thank you for the questions. I not meant to laugh at the question about colour, but it's a debate we always have. So more positively, we don't really do hard copies, so it's designed as electronics. Of course, when it's all made and put together, it's all in colour, and the bit that will be on LSR online would all be in colour. So Natalie does all the infographics, and then at the last minute I go to her, it's going to Scrutiny, can you do a black and white version, otherwise it won't print very well. So largely people would see it in colour. I think we did play around an awful lot last year trying to get away from grayscale into using different hatching so we could see it better, and maybe that worked better than doing what was a bit of a last-minute black and white job. But actually, if I've got a chance to reflect on that, we could probably go back to thinking about last year's and move away from grayscale to hatchings and crosses and the rest of it. So that, largely meant for colour, but we probably do need to look at how we do it in black and white. In terms of an annual report, last year, there's always a debate with an annual report around, do you look at everything around the health of the population, or do you pick on a particular topic? Last year's one, we did put stuff in around smoking cessation and lifestyle behaviour because I deliberately wanted to do a very broad spectrum of everything to do with health. To do that every year, to some extent, I think it loses its focus because it becomes a refresh of everything, and you don't get the chance to do what I would want to do, as the statutory duty would suggest, which is to pick on things that are important, that you want to highlight with people. Always more than happy to talk about what we do from us, and I suppose the other bit is it's my chance to point fingers at other people instead of beating up my own services. So the point really is to make recommendations and observations about the health of the population and what other people need to do about it. Obviously, more than happy to talk about the services that we do. So smoking cessation, plenty of stuff in Leicestershire Matters that going to always bring to the attention. We had a little bit of that actually in the performance report, but maybe there's not as much in the performance report about the performance of public health services within the council. But obviously smoking cessation is a really good news story for us. We redesigned the service, we did it digitally. We are delivering the national average per 100,000 population of smokers. But there was an East Midlands Public Health England report. The cost per quitter is not only the lowest of any service in the East Midlands, it's a third of the cost of the next lowest in the East Midlands. So I'm genuinely very proud of the work, not me, it's the rest of the team have done in redesigning services to do exactly the stuff that you're doing. So I suppose there's a point around, I'm in a privileged position to be able to choose the priorities that I put in my annual report. Always happy to provide a report to Scrutiny at a further meeting around lifestyle behaviour and lifestyle behaviour services, because I actually think I think we've done so much work that maybe the council's not so aware of in terms of redesigning services to be lower cost, value for money, but still keep that population principle in there. Lastly, in terms of recommendations, yeah, there's a particular one around weight management and tier 3 weight management. So not everything around weight management services for those people who are overweight and obese is a responsibility of me and the council. Bits of it are the responsibility of NHS England around bariatric surgery, for instance, for very morbidly obese people. And tier 3 weight management, the kind of bit between we're responsible for and what they're responsible for. It has been a call that I've made for some years that the point that Andy made about funding for public health was well made, but I'm comfortable enough with what we do with the resources we have available to us. But the NHS have not funded their bit of it ever since 2013. So for that particular one, yeah, it is a renewed call because I haven't seen them fund the bit that they need to. I can understand the funding pressures on the NHS, but if you're trying to build a pathway for those people who are overweight and obese from everybody, and as people get larger, they have more specific problems, there's a gap in the pathway, and I wouldn't want to shy away from exposing that.
Thank you, Mike. David.
An excellent report, and it's far easier to read and understand than the earlier ones. Is it possible to have a sort of sent out electronically in colour? I'd find it useful too. Do we have it? Right.
Yeah, I can confirm that.
Yes. Well, however, if we could actually, it would, as Ted says, it would be easier to read if we could. Yes. The reference to dementia I find interesting there, because I do wonder. I struggle now to do now the Leicester Mercury's introduced a hard Sudoku, which is impossible to solve.
You are on camera. Carry on, David.
No, there's an easy one and a hard one, and Valerie does the easy one, and I am determined to do that hard one, but I do wonder whether I'm falling into this. But anyway, no, this is an excellent report, and I would like, if there's anything we can actually do as members to further this, I really would like to help, because this is so, this is so interesting, and I think this could be so useful to the slightly older community and not so older community. Yeah, thank you.
Perhaps another year we'll do one on gaming.
Hi, yeah, obviously, we discussed it in the pre-meet, but I thought it'd be useful to bring it out at Scrutiny, just to understand whether or not there's any data that can sit behind the impact of loneliness and how people live and how they're managing with conditions if they're also lonely, and what impact is that having on our population.
Yeah, again, in terms of where we take that, I think I put in the recommendation, there's the work that Michael Rose within the council is leading around social isolation and loneliness, and the work that Neil O'Brien MP has been involved in Harborough around that as well. So I think we've got a story that will be coming out in the next year about how we coordinate and do more around social isolation and loneliness. The impact is an interesting one, and I know it's a discussion that we had earlier. that there's obviously graphs in there that I've presented around depression and anxiety. And then there is a evidence-based nationally and internationally around how social isolation and loneliness affects it. I would have wanted to, in the last year, when we talk about social prescribing, track the journey of people. So as they are kept connected in their communities, does that lead to a journey where they then don't end up with a diagnosis of depression and anxiety? Can't do that for a number of reasons to do with different data sets and the reasons why people consent to have their data collected. It would be nice, and we are working with NHS Digital to see if we can find a solution that, without breaching data protection rules, would enable us to track that journey from the community into the health service, because then I think that would prove the real worth of everything that I believe is the right thing to do against does it make an impact on registration and referral rates for particular conditions.
Interesting. Yeah, as you say, Neil O'Brien's really, I mean, even from the day I met him before he even got elected, he's been talking about loneliness, so it's obviously well on his agenda. But anyway, Ted.
I hope to just claim an interest there. I'm a district councillor and I'm the community cohesion champion, and I'm organising a conference for Charnwood on January the 17th on that. So various people at the county council will be invited to attend.
That's very good. Thank you very much. Well, thank you very much again, Mike. Another interesting black and white piece of paperwork.
Slightly old snooker commentary, isn't it? For the benefit of those in black and white, the pigs behind the green.
Some of us grew up in a black and white world, and I see now they've even done for some of the First World War pictures. They've now, some of them, the chap who did the Lord of the Rings has now colorised them. Incredible. I mean, I don't know why. Why does it make such a difference? It does.
Chairman, could I ask, are we doing anything more with this report?
Yeah, so in terms of sign-off process within the council, it goes to Cabinet 23rd of November, then on for debate at full council, particularly for twin-hatted members. You know, always happy to come out to district health and wellbeing boards, and you know there will be some of the kind of local area data, because some of that is about what you then do back in localities as well as the county level stuff. So there's always an offer around any of the health profile stuff to come out and do the tour of duty, so to speak.
Chairman, if I may. And I'm sure Mike won't miss this trick, since he's already alluded to the fact that he's now revving to go off the back of these figures to see just what the positives and how we can influence policy in the next few years is going to be. And I'm looking forward to your analysis, if I may, Chairman, in those areas, because vital for us to have in terms of multimorbidity. Thanks.
Yeah, I mean, that sounds good news. I mean, I think, as ever, I mean, every year when Mike's produced one of these annual reports, I mean, it does get a very good bit of publicity, I always think, around the community. But obviously, when it goes to full council again, all of us get an opportunity to have another look at it and bring it forward on our communities. I always take it to all my parish councils. I always don't take the whole document, but I take a summary of it, just so that people are aware of what's going on.
I'm also looking forward to the debate this afternoon from 2 o'clock on unitary, where, of course, a lot of the points this morning will actually wash back across and be quite interesting.
Which brings me, to the... thank you very much, Mike. That was absolutely great. And but that does close the morning session. We're going to reconvene at 2 o'clock, and at which point... I'll actually give you a bit of a... We're going to see a number of people. There's Simon Lawrence coming. There's Declan Keegan. I've said Byron Rhodes is going to come. Mike Sands is back. Cheryl Davenport's back. So we get quite a good chance this afternoon. And I will also point out to you, the bit of paper you've had in front of you ever since you sat down is in fact the running order for this afternoon. We don't have to take it exactly as it says. If people want to skip to a certain area, we'll do that in order. So we have some kind of control. So, thank you very much, and we'll see you all at 2 o'clock.